All right, so while we are waiting for Ange, can everyone hear me okay?
Yeah.
All right. So, Jackie, did you try to go on to Evolve and do the exercise?
Yeah, I went online and I did the Suzanne Ling for my first patient. I searched it first, and then I added her to the system because that was the first person that was in the book. So I added her to the system.
Okay, very good. So we are on week 9. CMA and Electronic Health Records, week 9. And next week and the week after will be break because of the holidays. And I figure I'll just give you guys that time to catch up on any exams that you need to complete and review if you would like. So Liz, how did you do with the Evolve exercise?
I think I did pretty good. The only thing I noticed on one of the ones where we were adding the information in that they gave us in the book to add the information, that it wouldn't let you move on to the second part until you'd completed the personal information. And the zip code it gives you is only 5 digits, and it was looking for the 9-digit one, and it wouldn't let me move on until I filled out the rest of that. So I just put in like 4 random numbers because it didn't give us the numbers. Is that okay?
Yeah, absolutely.
Okay. All right.
So what part was that? Can you point that out to me again?
Yeah, under the patient information, it's just the zip code. It gives you 12345 as a zip code, but it's looking for the 9-digit zip code in the actual. Page 51.
And I kind of had the same thing for that, like what Liz had. I thought after each page you had to save it and then go to the next page, but it actually wasn't letting you save anything until you actually got done all 3 pages. So it was kind of confusing because in the book it says to save each page. Right. So, and that's what I tried to do, but it wasn't letting me do it. So I agree with Liz. It's kind of conceiving, because you don't know what you're told to do, and it doesn't let you do it.
Right. So you don't have to save after every page.
No, you have to save at the end of the 3rd page. You fill out the first page, and then it tells you that you can't go to the, something's not saved. So you got to go to the 2nd page, fill that information. You can't save it there either. Then you go to the 3rd page, you fill that information, and then it'll let you save it. That's how it happened to me.
And how about you, Liz?
Yeah, I didn't even try to save it until I had done all 3 pages, but it worked then.
Yeah.
And that's what I would recommend. How about you, Diane? How did you do in your book?
I did fine. I entered 3 patients' names in, and I did chapter 4, which was print them out, and I was able to do that too.
Okay. And you really shouldn't have to print them to paper. You should be able to save them as a file on your desktop if you want. So you can create a folder right on your computer, and whenever it tells you to print.
I didn't actually print them. I got them to that point where I could view them before I printed them.
Okay, very good. All right. All right. So overall, everything feel pretty good about entering?
Yes.
Yeah. I agree.
so let's look. Let's go into our KINS book. And so I gave you 18 and 19. We can go over the answers in the study guide. Actually, sorry, a little backwards tonight. We're going to start in the textbook on page 303. All right. Hi, Scarborough.
Hi.
Hi, Ange.
Hello.
So do you guys have trouble every week?
It seems like we do, and I don't know. I mean, what I end up doing is calling the technician at, let's see, what is it?
At Network Maine.
Yes, I call him and we wait, and he says we're not on there, then he adds us.
Yeah.
And so that's the problem, is we don't get invited. So we come and set up early, but then they don't invite us, so I call, and he just figured it out. It took him a while, but he figured it out again. I told him.
I had the same problem.
You do too?
Okay.
I did.
So
Okay.
I know I mentioned this to you in an email, Jackie, but you have to be signed in and waiting on your computer by 5:20 or 5:25.
Oh, I was on at 10 past, so I can make sure that I have it. Now that I know that class is at 5:30, I'm on it way before that.
If you could please.
Okay.
Yeah. Thank you.
Because everyone is on the list to be invited. So I will contact Network Maine myself later on and find out what is going on, because there's no reason why you shouldn't be getting a call.
Well, he asked me what class I had, and I couldn't remember if it was the 401 or the 406. And he told me to hold on, and then he came back on. He said, "Yeah, hold on," and that's when I was able to get on.
What do you mean 401 or 406?
Well, because on Tuesday night I have class for the medical terminology, so I can't. It doesn't say like what the 401 is for terminology or the 406 is for your class.
Okay, that's the first I've heard of it. Okay, but I'll get in touch with Network Maine and find out what's going on. So, Ange, we were just going over the online assignment. How did you do with your online assignment?
Good. Yeah.
Do you feel comfortable with the software and how to enter a new patient?
Yes. It's easy.
Okay. All right, so turn to page 303 in your KINS textbook. And this particular homework, 18 and 19, basics of diagnostic coding and procedural coding. I specifically didn't want you to do any of this particular work because, number one, you don't have coding books. And not only that, you really don't want to spend an extra $500 on coding books as a certified medical administrative student, especially for how often you would use them. You only would end up using them in these two chapters. And the knowledge that you need for performing these two types of coding in your job may be minimal or extensive. It depends on where you end up working as an administrative assistant. As we've talked about many times before, you might end up in a specialty. And sometimes, more often than not, a specialty is a single staff, single doctor office. So in that respect, yes, you would need to learn diagnostic and procedural coding. But because it's a specialty, that means that you have specific codes that you use all the time, whether it is diagnosis or procedural. So for chiropractic, for instance, we have 35 procedure codes that we would use. Diagnosis codes, we might use, a couple hundred. And in your practice management system, all of those codes would be pre-populated. So you would just be able to choose from the list that has the description plus the code next to it. So that's why with Chapter 18 and 19, number one, being on the national exam isn't a problem. They might ask you questions about diagnostic coding or procedural coding, but they don't ask you to actually pick some, which is what we would do in our medical billing and coding class. We actually have 3 books that we use, an ICD-9 book, a CPT book, and a HCPC book. The ICD-9 is for diagnostic coding, as you see there in the scenario. They talk about ICD-9 meaning International Classification of Diseases 9-3 Vision Clinical Modification, or you see it as ICD-9-CM. So turn the page to 304. And you see some vocabulary there. So if anything, you might have some vocabulary on the national exam, okay, that talks about ICD-9. And over on page 305, we get to know a little bit about ICD-9. What is diagnostic coding? Well, first of all, to even begin diagnostic coding, we need to know what is an encounter. And an encounter is going to be used in all settings, including your hospital admissions. An encounter is any contact between the patient and the provider of service. Your diagnosis is determined based on the nature of the condition, the illness, the disease, the injury, or the congenital defect. So in medical coding, when we hear the terms assessment and diagnostic statement, these are actually synonyms for diagnosis. In your ICD-9 book, you are going to find that there are 2 main parts, the alphabetic index and the tabular. The ICD-9 manual is used to assign standardized numeric and alphanumeric codes to basic diagnostic written statements by the provider. You will have ICD-9 codes help track healthcare statistics, and they are used in practice management software, clearinghouses, third-party payers, and it's simply to reimburse providers for the services that they provide, and in doing so, the diagnosis codes tell the payers why the patient is being seen. So what is diagnostic coding? Diagnostic coding is simply the translation or the transformation of written descriptions or illnesses or diseases or injuries into numeric or alphanumeric codes. The accurate use of the ICD-9 manual is critical. Critical to accurate translation of those medical record diagnostic statements into the numeric and alphanumeric codes. The manual will identify disease or injury, and it will do so by using a 3-digit, a 4-digit, or a 5-digit code. So why do you think we use ICD-9 codes? We use them, first of all, we use it as a standardized system. Why? Because it's accepted and understood by all parties in the reimbursement cycle. I'm on page 305 under why use ICD-9 CM codes. It also creates a more convenient method of data storage and retrieval. It helps to maximize reimbursement to the provider. It shortens your claim processing time. And it helps to evaluate the appropriateness and timeliness of all of the medical care. So let's give you a little history about the evolution of ICD-9 coding. ICD-9 coding, or yes, ICD coding, basically classification systems were created and are used to organize the healthcare data and make it the retrieval more meaningful. The American Public Health Association, also known as APHA, they're the ones who recommended the adoption of this classification system in Canada, Mexico, United States, and then further recommended that the system be revised every 10 years. And this started in 1893. There are subsequent revisions that were called the International Classification System of Causes of Death. This was completed in 1900, 1920, 1929, and 1938. So you can see that this type of system has been around for a long time. The International Classification of Diseases was adapted for use in the United States, early 1950s. The ICD-8 actually provided the basis for coding morbidity and mortality statistics in the United States, and it served as the method of indexing all diagnoses and operative procedures in hospital records, and this was in 1968. Legislation has been passed to formally adopt the 10th revision or modification. And as you can see, ICD-10 has been delayed until October 1st, 2015, It was supposed to be effective 2014, but that didn't happen because of Congress. So let's take a look down at the bottom of the page, and let's just talk about what your book would look like. If you were to look in your book, if you had an ICD-9 book, you would see something like this on your page. So on the top left where you see number 3, that is your chapter. And that tells you that chapter 3 is the endocrine, nutritional, and metabolic diseases and immunity disorders. Then underneath you would have the section. So it is the diseases of other endocrine glands. And I mentioned earlier about 3rd, 4th, and 5th digits. Well, you have a category. Your category is always 3 digits, and it would be 250. Your subcategory, as you can see, is indented, and that would be your 4th digit. And your 5 digits would be the subclassification, and as you can see, that is indented as well. Right now, you don't have more than the 5th digit. When we get into ICD-10, we'll be using 7 characters. So how is the structure of the book set up? Well, every year, the ICD-9 manual is reviewed for changes, and it is published in October, and you will always use the most current year's coding manual to ensure that you are using the correct codes and billing to comply with regulatory guidelines. Depending on the publisher, the layout and the symbols and the color coding and some of the other features will vary somewhat. However, your format, your conventions, all your tables and your appendices and content and basic structure is going to remain the same. So you might end up with this big, heavy book that weighs a good 10 pounds, or you might end up with a little handheld book. But they all do the same thing. So, over on page 307, the ICD-9 book is actually made up of 3 volumes. Volumes 1 and 2, as I mentioned earlier, these are used for diagnostic coding by hospitals, your physicians, and all other providers of service. Volume 2 is the alphabetic index. And let me just refer back to volume 1 for a minute. That would also be known as your tabular index. And then volume 3 is used by hospitals to do inpatient coding. So your coding manuals, again, depending on the publisher, will have an introduction that provides the historical background. They might have conventions, anatomic illustrations, special coding instructions, all kinds of stuff. They should be full of the guidelines that you use to prepare your claim forms for Medicare and Medicaid services. And you always want to be using the current yearbook. Underneath your tabular index, or volume 1, your tabular index will be numeric listing of the diagnostics codes, and you'll have detailed descriptions. Your tabular index consists of 17 chapters that classify the diseases and injuries. And there are 2 sections that contain the supplementary classification codes, such as your V codes and your E codes. And then you'll have 4 appendices, and Appendix B was actually deleted October 1st, 2004. All of the chapters you will see are subdivided, and they are done so by the example that I just showed you on page 306. You'll have a category, then you'll have the subcategory, and then the subclassification. Your supplemental classifications on page 307. You will have 2 supplementary chapters in the tabular index. You'll have the V codes and the E codes. Your V codes are pretty much, they describe the factors that influence your health status and contact with the health services that cannot be classified elsewhere. Your E codes will describe any external causes of injury or poisoning. So your V codes, you might see someone come in for vaccination. That would be a V code. Or someone coming in for dialysis or chemotherapy. An E code would be anyone who has an automobile accident, or describe a place of occurrence, so where the event might have happened. So your V codes, just to remind you, are when a patient is not currently ill, but we need to explain the problems that influence their current illness, condition, or injury. And your E codes classifies environmental or external causes of injury, poisoning, and that type. The appendices, Appendix A is the morphology of neoplasms. You see that used more in the hospitals. Appendix C is the classification of drugs. Turn the page to 308. Appendix D is the classification of industrial accidents. And Appendix E, the list of 3-digit categories. And the 3-digit categories basically help to give you a listing of all the 3-digit codes and where to find them in the tabular. The conventions that are used in the tabular index, you will find abbreviations, punctuation, symbols, instructional notations, the related entities. These all assist us when we're trying to code. And so just by using them as guides is going to be crucial to accurate coding if in fact you spend a lot of time doing billing and coding. Your abbreviations. There are 2 primary abbreviations that are used in this book. You'll see that one is NOS, not otherwise specified, and the other one is NEC, not elsewhere classified. Your NOS is the equivalent of unspecified. And your NEC is not elsewhere classifiable. You will see that this is usually only when a coder lacks information that might be necessary to code the term to a more specific category. So again, no classification exists to match the wording. That's when we would use an NEC. You have 2 examples at the top of page 308 that you can refer to to give you an idea of how those would be used. Punctuation. You will have 4 basic forms of punctuation: brackets, parentheses, colon, and braces. And over on page 309, actually right up above that, you'll see the brackets, the parentheses, the colons, and the braces. Then over on page 309, you have the symbols. Your symbols are going to be used to designate the requirement of a 4th or 5th digit, or maybe even both. You might have new entries and revised text or codes. And if you look down below figure 18.4, you'll see the symbols in the box and what they stand for. Some other conventions will be bold type. The bold type is used for all codes and titles in the tabular. Italics. Italics type is used for exclusion notes and usually to identify any diagnosis that should not be used as a principal diagnosis. Your instructional notations, they appear in red type in the tabular. You'll see includes, excludes, notes, see also. And basically, when you're going and you're looking for terms, you have to read the before, the middle, and the end. You'll have code first, use additional code. Your related terms that you might see will be and with. And basically should be interpreted as and or. With should be interpreted to mean associated with or due to when it appears in the code title. Your alphabetic index is volume 2, and this will consist of the alphabetic list of the diagnostic terms and codes that are related. You'll have 3 supplementary sections here. One is hypertension table. The second one is neoplasm table, and the table of drugs and chemicals. And then you will have a separate index for your E-codes, which are your index to external causes. The main terms and the non-essential modifiers. Over on page 310, your main terms, they appear in bold. Your non-essential modifiers will appear in parentheses. Your modifying terms will be indented 2 spaces to the right underneath the main term, and they're called essential modifiers basically because they change the description of the diagnosis in bold type. And your subterms, those are going to be indented 2 spaces under the level of the preceding line, and they should be used on all when all conditions exist. The supplementary sections that you will find will be the hypertension table, the neoplasm table, the table of drugs and chemicals, and the index to external causes of injuries and poisoning. Volume 3 is, again, as I stated earlier, used in the hospital setting. So it's primarily used in the hospitals Your procedure codes actually consist of 2 digits followed by a decimal and then 2 or more additional digits. But if, as an inpatient coder, you can't find what you need in volume 3, you would be able to use the other volumes. So, how do we begin the coding process? This is where your diagnostic information or your written documentation of the visit is used to abstract and encode the diagnosis. And then you would demonstrate the use of the alphabetic index in the selection of the main and modifying terms, and then you would use the appropriate code or code ranges. And then you would go to your tabular and explain the importance of a tabular index. You always start looking in the alphabetic index, and then you confirm the encounter in your tabular index. So, you start reading documentation. You interpret and you abstract the medical documentation. So how would we do this? Well, look at the medical documents. You would start with the encounter form and the treatment notes, the operative report, the radiology report. All of these things are what we would start with to better diagnose a visit. So, what is an encounter form? An encounter form is known as a super bill, or a fee slip, or a charge ticket. So when you go into the doctor's office, they might still be using paper and they might not, right? So that fee slip follows you around the office from the beginning to the end. You sign in, they might put it on a clipboard and give it to the next staff member, and then it follows you to the room. The doctor will look at it, maybe make some notes on it, and then maybe even choose some codes, diagnosis codes, procedure codes, or if they're using the electronic record, they might have a laptop that they bring with them from room to room and use that to document your information, your history, your treatment, that type of stuff. So then after the encounter form, we have treatment or progress notes, which is the second most common medical document where you can find your diagnostic information. These are also called SOAP notes, S-O-A-P, and they divide the information into subjective findings, objective findings, assessment, and plan for treatment. Then we have the history and physical. This is basically the starting point of the patient's story of why is the person seeking treatment. So we want to begin with the patient's own words. What is their chief complaint? Then the physician will document the pertinent history, anything that has to do with medical, behavioral, and social factors. After the history, the patient will perform the physical exam. This will include his objective and subjective findings. Then the final section will be the doctor's HMP and include the assessment and the plan. Then the doctor will note his plan for treatment and his medical decision making, all based on his assessment. The discharge summary is used primarily for extracting the procedure and diagnostic information for patients. The operative report, this is for patients who underwent surgery as an outpatient or inpatient. Again, this will help us to extract the procedure and diagnostic information. It might even include the preliminary diagnosis and the procedure, or the final diagnosis and procedure. You could have a pre and post-op diagnosis as the same thing, and that's okay. So when you're using the final diagnosis, when searching for and selecting a diagnosis code, make sure you use all the supporting documentation. Your path lab and pathology reports, again, these also support and establish the diagnostic statement or statements. You have to extract the information, and how would we do that? There's basic steps. We want to analyze it, okay? What did the patient come in for? What's the doctor looking for? What is the doctor writing down? So we have to break it down. And if you look at page 311, figure 18-6, the diagnostic statement is cerebrovascular accident. So we would actually look up accident first. And then we would go look for cerebrovascular. Or GERD. You would simply look up GERD. Upper respiratory infection, you would start with infection and then look for respiratory. Then look for upper. All these different things. You have to look at what is the main term. Your main and modifying terms. The alphabetic index is organized by main terms. You have modifying and terms which are non-essential and essential. And then your subterms. Your main terms will indicate the condition, the disease, illness, or injury. Your modifying terms are indented 2 spaces below, and then your subterms are indented 2 spaces below that. And it will add more detail and modifying on the modifying terms. Your main term typically will be the primary condition. Your modifying terms will provide further specificity or detail, such as the anatomic site or the additional manifestations of the condition. Your main terms can also be found as an eponym, a synonym, or an acronym. An eponym describes a disease, a condition, or an injury that happens to be named after a person. Your acronyms are abbreviations of words that might create a new word. And abbreviations are slightly different. They're shorthand for common medical terms. So there are 2 important considerations. The first thing is that nothing can be omitted. Nothing can be omitted from or added to the diagnostic statement that is not documented in the patient's medical record. And then secondly, when the diagnostic statements are compared with a code description, the description of that code must match, and if there's no essential element of the statement added or missing. So it's really important to pay attention to what the documentation states. So what are the steps to finding a code. First thing we're going to do is read their report so that we can abstract the diagnostic statement. Then we're going to use the alphabetic index to search for the code or codes that best fit. And then we're going to the tabular index to confirm and verify the code matches the diagnostic statement. You never want a code from the alphabetic index, because you can look at it, but you should always confirm it from the tabular. When you use the alphabetic index, volume 2, you should be using only as an aid, because you always want to be looking it up in the tabular index afterwards to confirm it. If you see on page 312, they give you a figure 18-7, which is what an alphabetic index looks like in the ICD-9 book. And then if you look on page 314, that is what an actual page looks like in the ICD-9 book. Down below, the diagnostic coding decision tree, basically you have a series of questions that are called the decision tree. And this can help the medical assistant navigate through the alphabetic index for coding. So you see the decision tree over on page 315. And it shows you how to look in the alphabetic index and then how do you look in the tabular. So some examples of the steps in the diagnostic coding. What is the first step? Can you read the first step for me, Liz?
The diagnostic statement is cholecystitis. There is only one main term, cholecystitis. In the alphabetic index, the main term cholecystitis has a single code, 575.10. Turning to the tabular index, 575.10 states cholecystitis unspecified. The surrounding codes all add information that is not contained in the diagnostic statement. For example, 575.1 states cholecystitis, but a symbol convention to the left of the code contains the number 5, which means the 5th digit must be used for this diagnosis. Code 575.0 states acute cholecystitis. The diagnostic statement does not specify acute, therefore 575.0 adds inaccurate information. In the same way, codes 575.11 and 575.12 and 575.2 add information that is not contained in the diagnostic statement. Therefore, the final and most accurate code for the diagnostic statement, cholecystitis, is 575.10.
So you probably got lost after the second sentence, and that's okay. Basically, what you need to know is that when you see a code, like you see 364 up there on the top left-hand corner of page 314, it says disorders of iris and ciliary body. When you see that red dot, that tells you that you need to code to the next level, because you cannot use just a three-character code. There's something more that's going on. You need to go to the 4th or 5th digit. So when we change the diagnostic statement even just slightly, we can end up with a different code. So it's really important to pay attention to what the diagnostic statement might be. So let's turn to page 316 and talk about your V codes and your E codes. Let's see if we can do it in a way that doesn't make you totally lost. All of your ICD-9 books are going to have comprehensive instructional notes. And those conventions that are in the book actually help us as the coder to choose the most accurate diagnostic code or codes. When you see a discrepancy between your reference resources, including the text, the year's coding manual is the final authority. You always want to review your conventions and review and refer in instructional notes, code definitions, etc. Your signs and symptoms, they're coded only if the physician has not reached a determination of final diagnosis. Your subjective findings usually include the patient's chief complaint, and this is a statement regarding why they're seeing the physician. The objective findings are any measurable indicator that's found during the physical exam. So figure 18-10 at the bottom of the page on 316 is rules for coding signs and symptoms. You would use only if there's no final or determining diagnosis. If the person writes rule out, questionable, suspected, if they put this in the assessment, signs and symptoms are usually or can only be subjective and objective findings. The subjective is always the chief complaint or the patient's verbal statement. The objective is any measurable indicators found during the physical exam. Your signs and symptoms are found in Chapter 16 of your ICD-9 book. When we talk about coding suspected conditions, when a diagnosis is stated as questionable or probable, likely, or rule out, you want to code the patient's documented symptoms or signs or chief complaint first. So if a patient is asymptomatic or has a family personal history condition, you would use a screening code from the V codes section. When we have multiple coding, you'll see that there are some codes that require more than one code. You'll see use additional code. That usually means that there's another code to be used in conjunction with. Code first means if more than one code is used, code with notation code first. And multiple codes may be needed for late effects, complication codes, obstetric codes. And you'll see they give you some examples on page 317 of multiple coding and combination coding. When we're coding late effects and past medical history, your late effects can be a scar. Your late effects can be a problem lasting after an acute phase of illness or injury has ended. There is no time limit when there's a late effect code that's used. Usually it requires 2 codes. They have rules for impending or threatened conditions. So Jackie, can you read that for me, those 4 things?
If it did occur, code as a confirmed diagnosis. 2, if it did not occur, reference the alphabetical index to determine whether the condition was subterranean term for impending or threatened. Also reference the term entities for impending or threatened. 3, if the subterms are listed, assign the given code. 4, if the subterms are not found, code the existing underlying condition or conditions, signs or symptoms, and not a condition described as threatened or impending.
Very good. Coding infectious and parasitic diseases over on page 317. Multiple codes usually are needed for infectious or parasitic diseases because you always code first to identify the disease or the condition. So an example would be bacterial infection. Then you would secondarily code the organism that causes the infection. So streptococcal bacteria. When you're coding an organism-caused disease, there are two categories for identifying that, and you would find those in 041 and 079. You might see notes under there that says see also or use additional codes. It just depends on the diagnostic statement. Over on page 318, when you're coding for HIV, the key is whether or not the patient has symptoms. If they have HIV, it indicates that only the virus is present. If they have AIDS, this is a syndrome, and it is defined as a group of symptoms occurring together. And AIDS is usually a manifestation of and or symptoms that occur as a result of the HIV infection. And you want to make sure that you never code a patient as having HIV unless it's clearly documented as confirmed. Some coded complications might be postoperative complications that affect a specific anatomic site. Postoperative complications that affect more than one anatomic site. And then if the alphabetic index doesn't provide a specific main term or subterm to identify the post-op complication, you could classify the complication using categories 996 through 999. When you're coding the etiology and manifestation, this is the cause and signs and symptoms of the disease. You're going to find etiology and manifestation codes listed together in the alphabetic index. When you're coding neoplasms, as you see on page 318, you have figure 18-13. This gives you an idea of what looking at the table of neoplasms is like in the ICD-9 book. First, you will see the terms listed. Primary identifies the originating anatomic site of the neoplasm. So you would look over on the left under neoplasm, and you'll see it's in alphabetical order. And if you know that it's primary or secondary or carcinoma in situ or benign or uncertain behavior or unspecified, you would look at that column. And then the anatomic regions are listed alphabetically, so then you would go down below and see anatomically where is it. And then kind of come across and see what code you come up with. Your instructional notes. A lot of coding decisions for malignant neoplasms are usually between primary and secondary. Your in situ or in situ is used only when the diagnostic statement contains the exact phrase. When we see unspecified, that's used only when no pathology study has been done, and neoplasm is still described with terms such as tumor or growth. And then your uncertain is used only when the neoplasm's behavior is malignant and the tumor is not in situ or the behavior is unpredictable. You have 5 steps for coding neoplasms. And you want to use the table in the alphabetic index to determine the anatomic site. You determine the neoplasm behavior, if the neoplasm is malignant or not, link the appropriate table and column to the appropriate row, and then check in the tabular index. Coding for myocardial infarction. As acute, this is documented as such in the diagnostic statement, or it might be stated as a duration of 8 weeks or less. If it's chronic, it is going to be stated in the diagnostic statement, or if it persists after 8 weeks. If the MI is specified as old or healed without any current symptoms, it should be coded using codes for category 412, which actually means old myocardial infarction. And then code underlying condition or symptoms only if underlying condition is not known. Your arteriosclerotic cardiovascular disease. This is also known as ASCVD. This is classified to subcategory 429.2. There is an additional code that's used to identify whether arteriosclerosis is present. Hypertensive disease. This is high blood pressure, and high blood pressure is identified as hypertension. If your diagnostic statement does not contain the term hypertension or high blood pressure, the condition is coded as elevated blood pressure, not hypertension. So if we were to mention hypertension in the diagnostic statement, that does not mean that the combination code for hypertensive heart disease should be used. We should actually show the cause and effect relationship that exists between hypertension and heart disease. So we want to make sure that it's clearly documented in the clinical record or the diagnostic statement. Turn the page to 320. When we look at the hypertension table, you will see that it's very similar to the neoplasm table. Again, we would want to know, is it malignant, benign, or unspecified, and then follow the hypertension table down and look at what it's related to. Coding for pregnancy. When you code for an obstetric patient, this can be pretty challenging because you might have antepartum, childbirth, peripartum, and postpartum. You will have specific obstetric coding guidelines, and they will either start with the terms pregnancy or delivery. You would look for the subterm underneath each one regarding the condition. If there is uncomplicated prenatal and postpartum care for the mom and the baby, you would code using V codes. If the mother has a high-risk condition, the V codes would be used unless problem manifests into pregnancy. And if there is an uncomplicated delivery for the mother, it would be coded using category 650, and the V code would be used to describe the outcome of the delivery. So, on 5-digit codes in obstetric care, the 5th digits are used only for obstetric patients with complications. So before delivery and after. Over on the right-hand page, 321, you'll see in the left-hand column, it shows you what the index, the tabular index would like if you're coding pregnancy. And you can see there, it only gives you a handful of codes, but it tells you, is it complicated, what's it complicated by, and if there's any other specified or without mention. Your cesarean deliveries, code only to define the reason the cesarean delivery was performed. These do not describe cesarean deliveries as separate from your vaginal births. You also have outcome of delivery and live-born codes, which is V27, V30, V39. Your newborn coding. These are for babies that are considered newborn or perinatal for the first 28 days. Your newborn codes should never be used on a maternal record. If the newborn is healthy, code from V code category 30. This should be used in addition to any other chapter 15 code. Your live-born infant category, this is the 5th digit from the live-born infant category that's used when the 4th digit of 0 is assigned. The 4th digit of 0 usually means that the baby was born in the hospital. The 5th digit then specifies whether the birth was cesarean. And you might actually have other 4th digits that represent the births that may have occurred other than in your hospital. Under coding injuries, you want to classify first according to the type of injury and then by the anatomic site. When you're coding fractures, these are coded first by anatomic site and then by type of fracture. There is a code range for fractures, 800 to 829. An open fracture is when the skin has broken the bone. A closed fracture is when the bone is not exposed. And then we have burns. You want to code each burn separately unless specific combination codes are given. Your codes are then covered by site and degree, and then by the extent of the body surface involvement. All of your burn cases should have at least 2 codes and a third if the wound is infected. Some of the other types of wounds and lacerations that you might have would actually use a different 5th digit to show that they're infected and complicated. Actually, when they are infected, that means that they are complicated because you have more work to clean them out. With your burn codes, you will use a 5th digit for additional information, and that means that an additional code will be necessary to indicate infection. Turn the page to 322. You'll see the table there at the top, table 18-1. This actually determines the burn percentages in children. This is the Lund-Browder chart that determines that. If you look down at figure 18-16, you will see this is the rule of 9s to determine the burn percentages in adults and infants. So again, when you're coding burns, you want to code the burn to the site by degree. Under the main term burn, find the subterm for site and then the subterm for degree. If your burn is stated to be the same site but of a different degree, you will always code to the highest degree, highest level of specificity. When we use E-codes, again, your E-codes are going to describe an accident or an injury. And they are listed in separate tabular index and alphabetic index. So you want to have the nature of the event, the place of the occurrence, late effect of an injury, the intent, and the drugs and chemicals used. Some of your major categories for E-codes you'll see are transport accidents, accidents and falls, accidents caused by natural and environmental factors, late effects of accidents, suicide or a self-inflicted injury. You'll see over on page 323 They give you a whole list of the index. Your table of drugs and chemicals. This contains the classification of drugs and other chemicals. They are going to be used to identify poisoning states and external causes of adverse effects. If you look over on page 323 in the bottom left-hand column, they tell you what is an accidental poisoning, a therapeutic use, a suicide attempt, an assault, and undetermined. Diane, can you tell me what an accidental poisoning is?
Accidental overdose of a drug, wrong substance given or taken inadvertently, accidents in the use of drugs in medical and surgical procedures, and to show external cause of poisons coded with the Tubular Index, Volume 1, Chapter 19, Injury and Poisoning Category Codes 980 and 989.
Okay, Liz, what is therapeutic use?
Therapeutic use is an adverse effect caused by proper administration of the correct substance in the proper dosage.
All right, and what is suicide attempt, Jackie?
Suicide attempt is E962. It's a self-inflicted injury or poisoning. Never call the suicide attempt without documentation from the physician.
All right, and what is assault and?
Also, injury or poison inflicted by another person with the intent to injure or kill. E961-E962.
And what is undetermined, Liz?
Used only when neither accidental nor intentional circumstances can be determined.
Okay. So when we use E-codes with the table of drug and chemicals, your E-code is going to identify the drug or chemical that might be needed to add to the circumstance to clarify when it was a drug or chemical that was used in the issue. So your table include columns for poisoning that may be associated with each substance. And then the codes can be used with an E-code from other columns with one exception. Your poisoning code cannot be used with a therapeutic use code. V-codes, classification of the factors. This is where you basically are coming in contact with health service. So some of the things that you might see with this is a circumstance or an encounter with a physician or healthcare provider when someone really isn't ill or an injury exists. You can use a V code as a standalone code, or it might be a principal or secondary code. This is for people who are receiving chemotherapy or are going for some type of screening or receiving a vaccination. In your alphabetic index, under the main term history, you will see subterm personal and subterm history. So in your V code, you will have history of, and you will have personal, and you will have family. I'm on page 323 in the right-hand column. Diabetes mellitus or mellitus, depends on who says it. You always will require a 4th and 5th digit code, or 4th and 5th digit. Your 4th digit will describe the manifestation of the diabetes that might be present, and your 5th digit will describe the type of diabetes. And you see right there all over on page 324, the top left-hand corner, figure 18-18, it gives you 4th digit subcategories for diabetes mellitus. Your 5th digit will be required to code the type. Is it type 1 or type 2? Type 1 is juvenile onset and type 2 is adult onset. Your 4th your 4/5 digit codes that are used are on page 323, and they show you down at the bottom of the column there what those types are. So when we are billing, we are always wanting to maximize our reimbursement. So you always want to code to the highest level of specificity. And you want to link the diagnosis to the CPT. And you're going to do that by extrapolating the data from the documentation, using the current ICD-9 manual. Be sure that your diagnosis corresponds to the signs and symptoms. Review any data entry, make sure all of your digits are where they need to be and they're not transposed. Know the carrier rules and requirements, and make sure that you have everything completed, because when you have incomplete or inaccurate data, this is cause for denial of claims and reimbursement. So be responsible and become knowledgeable to make sure that there's no fraud that takes place in coding and claim submission. Adhere to ethical standards and assigning and reporting only the codes that are clearly supported by concise documentation in the patient's chart. And make sure you maintain and continually are enhancing your coding skills and keeping informed of the changes in codes, guidelines, and regulations. And I can tell you that that's probably the hardest part, is maintaining that knowledge, because I can't tell you the last time I actually got to read a book for fun, because I've been so busy trying to stay up on all of the changes that are coming down the pike for ICD-10, HIPAA, compliance, High-Tech Act, all that stuff. Because of my work, because of what I do to provide services to all the different offices, I need to stay on top of this information in order to provide the services that I do. So when you're in your place of employment, you want to be able to stay on top of the knowledge, stay on top of the training, get webinars or watch webinars. And there's all kinds of free ones out there. You don't always have to pay for stuff. And just doing some Googling and researching and reading some articles. So, before we review exercises, any questions on Chapter 18? When did I lose you all?
You didn't lose me.
It's a lot of information, and I understand that. So, to summarize Chapter 18, when we go into the doctor's office, and I think we talked about this already, and if I did, I apologize. We go into the doctor's office and we have a sore throat and an earache and a headache. That is our encounter, correct? So we just created an encounter with headache, earache, and sore throat. That's also our E&M, our evaluation and management. So the doctor comes in, asks us all kinds of questions. Do we drink? Do we smoke? Do we take medications? Do we have any allergies? Or even the nurse might do that. The doctor will come in and confirm it. How long has this been going on? When did it start? What makes it feel better? What makes it feel worse? And then assesses the situation and, might give us some extra strength of powerful headache medication, might tell us to take an antibiotic for our sore throat because they tested us for strep and we have strep throat. And what was the other one? Earache. Oh, and the antibiotic for the strep throat will take care of the earache. So fill the prescription, take it as prescribed, and follow up with me in 10 days. So we're going to diagnose the strep throat, the earache, and the headache. And we would do so by looking in the ICD-9 book under headache, sore throat, and earache. Now, earache might show up as otitis media. So, what I want you to do is create a split screen on your laptop or computer and open up Google on one side and have the little lecture in the other. And what we're going to do is use Google and just type in, for the heck of it, headache. And I want you to type in headache ICD-9 code. And when you do that, it should come up with a bunch of different things to choose, such as 2012 ICD-9 CM diagnosis code 784.0, and the website is www.icd9data.com. Careful coding for headaches, ICD-9 CM diagnosis codes, 339 codes, and then 784.0 headache, www.findacode.com. So what I would like you to do is click on the 784.0 headache, which brings you to www.findacode.com. So if I don't have my coding books with me, I will Google an ICD-9 code. And if I don't go get it from the AAPC website, I'll use the Find a Code, because they're usually pretty right on top of things. Because I don't always remember my username and password for AAPC. So if you have, yep.
I cannot go online. It needs authorization, something like a username.
Okay. So what I'd like you to do when you go home is try this. Okay. So just follow along for now.
Okay.
So findacode.com brings up the code 784.0 for headache. And it lists underneath it the ICD-9 versus 1 reverse index lookup, code history, anatomy and physiology online for coders, dictionary definition. Now, you don't have to have an account, because really you're just looking for the code right now and any description it might give you. So I usually click on the plus sign on the left there at the top, where it says ICD-9 version, volume 1, chapter and section guidelines and notes. Is everyone following me so far? Okay. And so it gives me it expands, and it says click to view and hide additional coding information. And then it shows you symptoms. And then it says symptoms involving head and neck. And then it expands even more, and it says headache, throat pain, swelling in head and neck, aphasia, voice and resonance disorders, other speech disturbance. So basic documentation, if you did not have ICD-9 codes in your office as a resource, you would be able to come online and find it. And I would always use in the Google, in the trying to find it, ICD-9 code. So whatever your main term is, and then ICD-9 code, or ICD-9 code for, and then whatever the main term is. Okay, does that help? All right. So then let me give you some answers to Chapter 18 in the study guide.
Doreen,
Yes.
could you just save this find a code in your favorites
Yes, you could.
and just go use it that way?
Absolutely.
All right.
I'm going to let you guys do some of the work. My voice is going on me. All right, what do we have for vocabulary for number 1, Jackie?
Diagnosis.
Yes, diagnosis. And how about number 2, Liz?
Encounter.
Yes. And number 3, Ange?
Assessment.
Yes, assessment. And number 4, Diane?
Chief complaint.
Yes. And number 5, Liz?
Manifestation.
Manifestation. 6, Jackie?
And alphabetical index.
Alphabetic
Alphabet index.
All right. 7, Ange?
Auxiliary diagnostic services.
Yes. 8, Diane?
B and or.
Yes. 9, Liz?
Chapters.
Chapters. 10, Jackie?
Code first.
Code also. And then 11, Diane?
Coding.
Yes. 12, Ange?
Convention.
Convention. 13, Liz?
Diagnosis.
Yes. 14, Jackie?
Diagnostic treatment.
Diagnostic statement. 15, Ange?
Etiology.
Etiology. 16, Liz?
Exclusion and excludes.
Yes. And 17, Jackie?
I didn't get that one.
It is history and physical examination, or history and physical. 18, Diane?
ICD 9 CM.
Yes. 19, Ange?
Principal diagnostics.
Yes. 20, Liz?
C.
Yes. 21, Jackie?
C also.
Yes. 22, Ange?
C category.
Yes. 23, Diane?
Subjective finding, objective finding, assessment, and plan for treatment.
Yes. And 24, Liz?
I wasn't sure if that one was use additional code or code first.
Nope. Use additional code.
Okay.
25, Jackie?
I had diseases, illnesses, and injuries.
25 is with mention of, and associated with. All right, skills and concepts. Did I have you do skills and concepts?
Yes.
Okay. Skills and concepts. Number 1, the answer is D. Number 2, the answers are 3-digit, 2, subcategory, and subclassification. Um, the next one, or the next part, up to volumes 1 and 2 are used for diagnostic coding by hospitals. That's number 3. Volume 1 is the tabular. And then chapters are broad sections. And volume 2 is called the alphabetical index. And volume 3 is used for hospitals. So number 3, the answers you should have there are volumes 1 and 2. Volume 1, chapters, volume 2, and volume 3. Matching the following terms on number 4, you should have B, D, A, and C. So 4 should be B, D, A, and C. All right, number 5 should be 4th digit. 6 is the V code. 7 is the E code. 8, match the following terms. What do you have for that, Liz?
I have it right in the order that it's listed.
Yeah.
Me too.
Yeah, me too.
Have a
Yes, that would be correct. Good job. You thought they were trying to trick you, didn't you? All right, number 9 should be NOS, right?
Yeah.
And number 10, NEC.
Yep.
Number 11, the answer is C.
Question mark.
Number 12, bold and italics. Number 13 is bold. 14, italic. 15 includes. 16 excludes. 17 notes. 18 C. 19 C category. 20 C also. What do you have for 21, Liz?
Use additional code.
21 would be code first.
We have that as 8, Doreen. We don't, after C, for us, 4 was C, 5 was C category, 6. I don't know if that shows it on yours, but it's not showing the same on ours.
All right, hold on.
You went from 4 to 19, 18, 19.
I did?
Sorry, you did.
No, she. She just continued on. She just didn't start over at 1. After she went past 14 on the one above it, our number started
Right.
back over at 1, but she just continued
Right.
counting.
Right.
Sorry about that.
That's okay.
Okay.
All right, so where are we?
8, I think.
8.
Number 8.
Okay, so then the word should be interpreted to mean and
And.
or. It should be
And
And.
and, right, okay. And then with, and then when we match the following, main terms do what?
Appear.
They
Appear in
appear in
bold.
bold. Modifying terms are
Indented 2 spaces
Indented
to
2
the right.
spaces to the right.
Under their main.
yep, and subterms are
A.
Always.
always indented to additional, and modifiers are found,
In the alphabetic index.
yes. All right, fill in the blanks. You should have hypertension table, neoplasm table, and table of drugs and chemicals. The next one, you should have external causes of injuries and poisoning. Then the hypertension table, malignant hypertension, benign hypertension, unspecified, and neoplasm table. And cancerous, or non-cancerous growth, sorry. Okay. Which is not part of the diagnostic statement? What did you have?
E.
E, nurse's note. Okay, and what is number 2, Diane?
in counter form.
Yes. 3, and.
Treatment notes.
Yes, treatment notes. And Liz, number 4?
History of physical exam, chief complaint, and CC.
Yes, and you can have H&P, chief complaint, and CC if you wish. Number 5, you would have discharge summary. 6, operative report. 7, Jackie.
Radiology, laboratory, and pathology.
Yes. And 8, Diane.
I never can say it. CEPO, eponym.
Eponym.
Eponym. There we go.
Okay. And
Yeah.
9, Liz.
Acronyms.
Yes. And 10, Liz.
Abbreviations.
And 11, Diane.
Sure. Synonym. Yeah, right.
Synonyms.
Synonyms.
There you go. Perfect. And 12, Liz.
Decision tree.
Decision tree and decision tree, yes. All right. So let's look at the coding exercises just for a little bit. And we're only going to do a couple. You can use your Google. And what I want you to do is, the best thing to do when you're looking at these exercises is to, what do you think is the main term? All right. So the main term in number 1 would be birthmark. So Google birthmark, ICD-9 code, and I'll ask each one of you what you come up with. everyone have it? What do you have, Liz?
I have 757.32.
Yes, that's correct. Did everyone else get that? Okay. Diane?
No, well, by saving that in there, I guess you have to sign in and be sign into an account. So yeah, I have to get out and do it over.
Okay, I would just use Google every time
Yep.
and then go from there. Because you can also use icd9data.com. That's another site that I use is icd9data.com. All right, number 2, Mr. Epstein suffers from Bruch's disease. What is the main term there, do you think, Jackie?
Bruch's disease.
Yes, Bruch's disease. And the reason why we would look it up under Bruch's disease first is because it was actually named after someone. This is that eponym. Number 3, Jenny developed bronchitis over spring break after inhaling gas fumes while sitting in a traffic jam. Bronchitis. Number 4, Carolyn has experienced dumping syndrome periodically since her gastric bypass surgery. What do you think that would be, Diane? What main term?
The dumping syndrome?
Yes. Number 5, what do you think would be the main term there, Liz?
Pain when urinating.
Yes. And what do you think would be the main term for number 6?
Vomit. Okay.
I would say nauseated or nausea. So what you can do is you can take some time to just do some of these. You don't have to do them all. As you can see, it can be done without an ICD-9 book, okay? And then, as I said, it's not something on the national exam, but it wouldn't hurt to do like, every third or fourth one and just guess the main term. And if you want the answers, just send me an email and I'll send you the diagnosis codes if you want to check them. Can we take a quick break here in about 5 minutes and then come back and finish up?
Sure.
Okay, thank you. Okay, are we all back?
No, Liz is still gone and Angie.
Okay.
Dorian, I found that this part was pretty easy. Well, not pretty easy, but the 19th chapter, that was harder
Yes.
for me. A lot harder. I shouldn't say it was easy because it's definitely not easy, but once you got used to it, it was pretty easy to find out what you were, what you were looking for.
Exactly. Yep.
I'm kind of anxious to get into it.
It's really fun. I truly love billing and coding.
Well, that's my next class with you, I am assuming.
Oh, great. Yep. The one and only.
Yeah.
Yeah, getting into the computer part, into the Sysmo or whatever, that was pretty interesting. I like that idea. I like adding that patient in there, but I only added one because I thought that's what you only wanted, was just one person to get used to how it worked.
Yep, just to see how it works.
So what do you got? Right there. I'm glad they didn't run the whole bunch more. Listen, guys, you got no seat to go. No, you're going to go for me.
Okay, so let's turn to our textbook. Basics of Procedural Coding, page 326. We see that we have vocabulary terms on page 327. So the big things with procedural coding is very similar to diagnostic coding, because you still need to look in the alphabetic index. You still need to go into the tabular to confirm the code. You can look up things using the eponyms. You have HCPCS, which is called the Healthcare Common Procedural Coding System. It's also known as your Level 2 codes. But this is where we start talking about new patient, patient status, place of service codes, providers, physical status, bundled codes, unbundled codes, category codes, crosswalking, established patient guidelines, and that type of stuff. So turn the page to 328. So page 328 in your textbook. So the evolution of CPT coding, getting to know the CPT, and your CPT manual. Your CPT manual is descriptive terms and identifying codes that actually report the medical services and the procedures that are performed by the physicians. It helps to provide a uniform language that will describe the medical, surgical, and diagnostic services that enhances reliable communication among all of our physicians, patients, and third parties. Your CPT system uses a 5-digit classification setup, and what this does is it encourages the use of standard codes or terms to document the procedures in the medical record. It helps us to communicate the accurate information on the procedures and the services to agencies that are concerned with the insurance claims. And then it provides basis for a computer-oriented system to evaluate the operative procedures. It also helps to contribute information for actuarial and statistical purposes. You'll see that there's Category 1 codes, and this is the standard 5-digit code that we will refer to from here on out as the Category 1 code. These are located in the tabular index, also called the main text of the CPT, and you will see that they are arranged by sections. Each code has a description or service of procedure being performed. When we have a product that is pending U.S. Food and Drug Administration approval, this can actually be assigned a Category 1 code before the FDA has approved it for use. When that happens, it will be listed in Appendix K, and it will be identified in the tabular index of the CPT in different ways. The codes are tracked by the AMA to monitor FDA approval status. Your bundled and unbundled codes, they indicate the procedures or services that are usually grouped together and paid for as one procedure or service. When you have an unbundled code, this is used when the components of a major procedure are separated and reported separately. Your Category 2 codes, these are for supplemental tracking that can be used for performance measurement. It cannot be used as a substitute for your Category 1 and is not part of billing. It would describe clinical components typically included in the E&M services or clinical services, and more often than not you would find the 5th digit is the letter F. Category 3 codes are temporary codes that are assigned for emerging and new technology and services, and usually procedures that have not been officially added to the main text of the CPT manual. You will find that with these codes, you might have a 5th digit with the letter T, and you will find that these are going to be used in billing and reporting if there is no code in the main text that accurately describes the Category 2 code that matches your documentation. Modifiers, over on page 329, you'll see that modifiers actually give meaning to a service or procedure that may have been altered by some specific circumstance. But it doesn't change the definition, it just helps to indicate if it was a bilateral procedure or if there were two surgeons. Your CPT content, over on page 329, you'll notice that figure 19-1 gives you a CPT code example. You'll see that when they have a hyphen, it indicates an actual range of codes. When there's a single code, that means that it's truly a single code that would be used. And when you see a comma, it indicates that there are multiple codes. So that's a good indication of what CPT might look like. The content of the CPT manual usually includes, depending on the publisher, the complete alphabetic index, and it also includes instructions for how to use the book. You'll have a main text, which is your tabular, and if you turn to page 330, your main text is actually composed of 6 sections. It also has guidelines and notes, conventions, and 14 appendices. In the index, you'll see that there are 2 primary divisions. The alphabetic, which is the guide to finding the data in the body of the book. So it's listed by the codes or code ranges as I just indicated to you. And then the main text or the tabular text. In the tabular text, it's divided into 6 broad sections, and you'll see those 6 sections listed in your book there on page 330. It's the E&M, the anesthesia, the surgery, which includes all of the body systems, radiology, path and lab, and medicine. Over on the top of the right-hand column in table 19-2, you'll see how these are broken down. You'll have sections for surgery, and underneath you'll have subsections, like it indicates there, musculoskeletal, and then there might have a category that lists application of casts and strapping, and then subcategory body and upper extremity. In the subsections of the book, you will see that it will list below the section and indent 2 spaces. And when it does that, it usually describes an anatomic site or an organ system. As you saw in the ICD-9 book, we had a category section. The same thing in the CPT book. We have a category, and then listed below it, you'll have a subsection, and it will be indented 2 spaces. This is going to refer to a specific procedure or service, and it might also indicate a more specific anatomic site. With your subcategory section, this will be the lowest level of code description, and this is usually listed below the category and is indented 2 spaces, and this one will provide even more specificity. Your E&M section will contain the codes for different types of encounters or visits that patients have with providers. So if you think about all types of providers that you could have a visit with, ear, nose, and throat, OBGYN, podiatrist, orthopedist, chiropractor, dentist, they all have their own specific E&M code. An emergency room visit is an E&M code. A consultation is an E&M code. Surgery visit consultation is an E&M code. And those codes actually range from 99201 to 99499. Your E&M subsections and subcategories include different types of services. Underneath the subcategories, they will have further classification into the different levels of the services that are identified by specific codes. And it's even written to further modify or describe the service or procedure that is performed. Underneath your anesthesia section, this includes codes for anesthesia services that are rendered by the anesthesiologist and the anesthetist before, during, and after the surgery. You'll see the code ranges there in your book, and the codes will include the types of anesthesia that's given, any other support services, and monitoring. For your surgery section, this is actually the largest section in the CPT book. It includes standardized codes for all invasive surgical procedures that are performed by the physician. You'll notice that it is divided into subsections that are identifying the body systems, and your subsections typically will further be divided into categories and subcategories. Your radiology, your pathology, and your laboratory sections These will include diagnostic imaging, x-rays, scans, and therapies and treatment that are used in treatment for cancer. They will also include diagnostic tests that are performed on bodily fluids, tissue, including urine, blood, sputum, feces, all kinds of stuff. Your medicine section, all on page 331, those range from 90281 to 99199 and 99500 to 99607. This will include many varied subsections, categories, and subcategories, and you'll see that the medical specialties are grouped in this section. You will also have non-invasive diagnostic tests that are included here. The conventions of the CPT main text you'll see that they have special symbols as well. Figure 19-2 on page 331. Those are the main text conventions that you see in the CPT book. The CPT book, like the ICD-9 book on page 332, has guidelines. And those guidelines are found at the beginning of each section and some subsections of the CPT manual. It has added definitions and descriptions that are necessary to interpret the reports and procedures so that we can pull the information from it to code. So basically the CPT book is written to assist and help us understand the circumstances. So when we're selecting a code without reading the guidelines, this will usually lead to an incorrect code being chosen. When we see notes, notes are typically found only in the category, subcategory, or code description area of the CPT book, and it usually will apply only to the designated group of codes that follow the note, unlike your guidelines, not to the whole section. When we see unlisted procedure or service code, occasionally an accurate specific code cannot be found in the CPT book. In each section, non-specific codes are provided. They're called unlisted procedures and services. We can only code when there's no code in category 1 or 3 that provides an exact match. And if we use an unlisted procedure or service code, it usually ends in 99. And when we do that, we have to send a special report with the claim form to describe the procedure and the service. Appendices in the CPT book, just like in the ICD-9 book, Appendix A are the modifiers. Appendix B, summary of additions. I'm not going to go through each one of them. You have them right in your book on page 332 and 333, and it describes what each one is. When we are coding from the CPT manual, just like with the ICD-9 book, we had the beginning process. So with the CPT book, the same thing. We have medical documentation. So there are steps to beginning the coding process with the CPT book as well. We need to do the encounter form, do the history and physical, the discharge summary, the op report, the pathology report, and the radiology report. You will find that many providers have the CPT and the ICD-9 codes pre-printed on their encounter forms or their charge tickets. We need to review the medical record carefully and compile abstract of all procedures and services rendered during the encounter. We update the encounter forms annually to ensure that the code additions, changes, and revisions appear on the pre-printed forms. Some of the steps that we should take are outlined in the chapter. They apply usually to all of the CPT book. There are some special considerations and differences that might apply to your E&M and your anesthesia sections. And when that is the case, what you want to do is you want to make sure that you read, you analyze, and you abstract the procedure or service that is documented in the medical record. Make sure you compare it with the encounter form, the operative report, or any other documentation to ensure that you are coding and billing or coding all of the services that have been done. When we abstract the information, what does that mean? Sorry. Abstract is over on page 333 on the right-hand column of your book. When we abstract data, what's happening is that we're breaking down the main terms and the modifying terms. The main term is usually that primary procedure or service that is performed. Your modifying term will further define or add the information to the main term. Then your main and your modifying terms are used to find the code or the code ranges in the alphabetic index. So the code is selected, it's confirmed by reviewing the guidelines, the notes, the conventions, and the main text, just to make sure that you're accurately coding what has been done. Using the alphabetic index, this is a comprehensive alphabetic listing of all of the procedures and services. It is only used to aid in finding the main term to evaluate whether or not you have selected the proper code. This is not a substitute for the main text. Remember in the ICD-9 book I told you do not code from the alphabetic index? The same thing goes for the CPT book. Do not code from the alphabetic index. The index is very similar to that and found in any textbook. You have the listing of the main terms and then any modifying terms, and then you go into the rest, the tabular, and you reference the codes and you pick the correct code. Your modifying terms, these are indented 2 spaces below the main term, and they further aid you by describing or adding information and defining and narrowing it down to search for the appropriate procedure. This will affect your selection of the appropriate codes. When you are identifying the main and modifying terms, look at table 19-3 on page 334 in your textbook. You will notice it gives you a code, and then a main term, first, second, third, and fourth. So if we were to look up cystoscopy, a diagnostic one, there's no code. But gastroscopy, esophago with biopsy with fulguration of lesions, we might find it ranges in the 492000 area. We would drill down to find the most appropriate code for the highest level of specificity of what is done. Just like the ICD-9 codes, we are taking the procedural codes to match the documentation. So there are 2 rules that should be followed when you're coding any procedure or service. And I'm on the bottom column on page 334. Be specific. Be as specific as possible when you're coding. And never add any words, modifying terms, or descriptors to what is being done. Do not assume. Always query the provider. When you are searching the alphabetic index, begin searching by using one or all of the 4 primary classifications or types of the main and modifying terms. What do I mean by that? Well, you'll see right there, it tells you searching the alphabetic index. Look by procedure or service. Is it an exam, an excision, a scope, a revision, a repair, or a damage? That is how you would start. Or you could look in organ or anatomic site, or condition or illness, eponyms, synonyms, abbreviations. These are all different ways to be looking for your procedure codes. So you would first list the procedure, then the organ or the anatomic site, or the condition. Use the name of the performed procedure or service, or the organ or anatomic site. Over on page 335, using C and C also. C will point you to another location in the alphabetic index to find a code or code range. C also points to additional codes or code ranges in the alphabetic index that might be useful to the code that's found in the original search. When you use the semicolon, this is at the end of the main description, and it simply indicates that there are modifying terms and descriptions that follow. So every indented description below a standalone code is related to that standalone code. With your standalone codes and code ranges, if you look in the alphabetic index, a procedure or service may list a single code called a standalone code, or a range of codes that are possible, and they might match the medical documentation. So always remember that in your alphabetic index, the index is designed to guide you to the most suitable code to match the documentation. It might not provide specificity, but that is the job of the main text to do that. With your standalone codes, due to the complexity of some of the procedures in the diagnostic tests, there might be a single standalone code or a range including one main term with several variations of the main procedure or service. So in some cases, they might be listed for the same service or procedure, leading to matching medical documentation with codes in the main text. And if you look at table 19-4, you'll see what I'm talking about. If you see, all of the main terms are cystourethropy. But if you look at the modifying words underneath, you see that it could lead to different codes. You okay, Ange?
Yep.
Okay.
Yes.
So what are the steps for using the alphabetic index? You want to abstract the procedures or the services from the documentation. You want to determine, do you have main or modifying terms from the abstracted information. Select the most appropriate main term to begin your search in your alphabetic index, and then select one or more of the modifying terms if needed to narrow the search. If you don't have a main or modifying term, then you might have to keep searching by using a different main term. You want to find the code or code ranges that include all or most of the description of the procedure or service that you find in the medical record. Disregard any code or code range that might contain additional descriptions or modifying terms that are not found in abstracted information or medical documentation. And make sure you write down the code or code ranges. When you are using your tabular index over on page 336, once the codes are selected from your alphabetic index, you then go into your tabular, which is your main text. You find the code, you follow the decision tree, you watch for the conventions, the symbols, any guidelines or notes, and you just determine, is it correct? You would have to look up each code or code range. You want to make sure you read the section guidelines and the notes to see if you have to use additional codes, add-on codes, or modifiers, and then check to see if the code is a contraindicated code. Some other steps might be to turn to the main text and find the code first there. Compare descriptions of the codes with the medical documentation to verify you have all or most of everything. And again, read the guidelines and the notes for the section or the subsection of the code. You even need to evaluate the conventions, especially if they have an add-on code, because you might have an exemption to modifier 51 and you won't know that if you don't read all your notes. Determine if there's a special report that is required, because if you don't send the report, you're not going to get paid. Record CPT codes selected in the medical record documentation next to procedure or service performed, an inappropriate block of insurance claim form. In CPT, you have a coding decision tree, which is usually just a series of questions that assist you in choosing the most appropriate code. And you'll see in your textbook on page 338, they show you how to use that decision tree. On page 337, for surgery coding, always review the current year's guidelines for your surgery section. Be sure to read through the guidelines and the notes, because you will always have answers that you'll find here when you need to determine the most accurate code. The surgical package definition, typically this will describe and include local infiltration, which is a digital block or topical anesthesia, one or more related encounters, E&M encounters on day of or day before, and then immediate postoperative care, including documentation, patient's medical record, and talking with family and or physicians. So with the surgical package, it would describe typically writing the orders for the post-surgical care, evaluating the patient in post-anesthesia, and typical post-operative follow-up care. Underneath excision of lesions, if the incision, excision, or trauma requires an intermediate or complex closure, the repair by the intermediate or complex closure is coded and reported separately, and that would be because it is more extensive. A simple repair is usually a superficial wound. An intermediate repair is layered closure of one or more deeper layers, and a complex repair is would be wounds that require more than a layered closure. When we talk about repairing wounds or listing the services for repairing wounds, they have to be measured and recorded basically in centimeters, whether they're curved, angular, or stellite. If you have multiple wounds, you add together the lengths of those that are in some classification, in the same classification, and then from all of the anatomic sites that are grouped together in the same code descriptor. So if you have head and shoulder and cheek, you might be able to add the cheek and the head, and you would have to do the shoulder separately. Debridement is considered a separate procedure only when gross contamination requires prolonged cleansing, and wound repair that involves nerves, blood vessels, and tendons should be reported under the appropriate system for repair of those structures. Fractures over on page 338. We have closed fracture, open fracture, closed treatment, and manipulation. What is a closed fracture, Liz?
The fractured bone does not protrude through the dermis or epidermis.
And an open fracture, Jackie.
The fractured bone cuts through the skin layers that can be directly visualized.
And closed treatment, Diane.
The fracture site is not surgically opened, exposed to the external environment, and directly visible. The third methods of closed treatment of fractures are 1, without manipulation, and 2, with manipulation, and 3, with or without traction.
And what is manipulation, Ange?
Attempted reduction of restoration of a fracture or dislocated joint into its normal anatomic alignment by manually applied forces.
Okay. And then we have open treatment and percutaneous skeletal fixation. Grafting of coronary bypass. This is where we have venous grafts and arterial grafts. Your venous grafting codes cannot be used as standalone codes if the arterial grafts are also used. To report a combined arterial venous graft, 2 codes must be used. 1 would be the arterial graft code, and 2 would be the appropriate combined arterial venous graft code. You'll see under maternity care and delivery, we have antepartum care, delivery, and postpartum. Antepartum is the initial and subsequent history up to the 28 weeks. Delivery includes admission to the hospital, and postpartum includes hospital and office visits. Your E&M services and HCPCS codes. Your E&M section, this is divided into broad sections like office visit or consultation. And I mentioned that earlier when we were talking about ICD-9 code. You'll find that the E&M section in the CPT book is then further divided into subcategories. And then you actually have 2 steps in choosing the correct E&M code. Was it done in a what place of service was it done in, and what is the patient's status? Over on page 341, you'll see an example of initial nursing facility care and what a page of E&M looks like in your CPT book. It talks about a new and established patient and subsequent nursing facility care. And when you're looking at this type of stuff, as I mentioned early on, you need to read the before, the middle, and the end. You see just in this example, you have notes right underneath new or established patient. You really need to read that stuff before you actually consider using codes, because you need to know the before, the middle, and the end. When you're identifying the place of service, back on page 339, your choices are new or established. What is a new patient, Liz?
One who has not received any professional services from the physician or another physician of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years.
Yes, and what is an established patient, Jackie?
One who has received professional services from the physicians or another physician of the exact same specialty and subspecialty who belongs to the same group practice within the past 3 years.
Okay, and what about the levels of service? What are the 3 key components for determining the level of service? Diane?
The 3 key components for determining the level of service for EM codes are history, examination, and medical decision making. The 4 contributing factors are counseling, nature of present problem, coordination of care, and time.
And what are the levels of history, Ange?
To understand the levels of the history, it is important to know the definition and components of the patient history. The history relates to the patient's clinical picture and depends on the patient for answers to specific questions.
Okay, and what about examination, Jackie?
The examination is divided into the following levels. It has problem-focused examinations. It has expanded problem focused examinations. It's got detailed examinations and comprehensive examinations.
Very good. And what about the medical decision making? What are the three elements for that, Liz?
The number of diagnoses and or management options, the amount and or complexity of data obtained, reviewed, and analyzed, and the risk of significant complications and or morbidity and mortality.
Yes. And what are the four levels of complexity in that decision making? Diane?
The four levels of complexity in medical decision making are straightforward, low complexity, moderate complexity, and high complexity.
Yes. And what are the contributing factors, Ange?
Their counseling.
Yep, and what's the other one?
I'm sorry?
What is the next one?
The nature of presenting problem,
Yep.
coordination of care, and
Yep.
time.
Very good. Anesthesia coding. Codes for anesthesia are listed primarily in the anesthesia section. And you'll find that these codes are based typically on the anatomic location of the surgery that is performed. With anesthesia, the coding differs from any other form of coding in that the standard formula that has been established is B plus T plus M. And this is the base unit value plus the time units plus the modifying units. The formula is an RVG that is assigned a numeric value to each service based on the level of complexity, which is called the basic unit value. The T is the time unit, which is based on time during which the anesthesia was administered, and the hours and minutes are actually recorded in the patient's chart. Over on page 344, it talks about the modifying units, and you see the physical status modifiers and the qualifying circumstances modifiers. You'll see, based on table 19-6, that sometimes the anesthesia is provided in situations that make administration more difficult. So it includes the provision of anesthesia in emergency situations to patients of extreme age during use of controlled hypotension and with hypothermia. So there are 4 qualifying circumstances, also known as QC codes. And each of the 5-digit codes is preceded by a plus sign symbol indicating that this is an add-on code. And then with your physical status modifiers, this is the second type of modifying unit used in anesthesia, coding the physical status. And you'll see that the first letter is always P, and it's ranked 1 through 6. Radiology coding. Basically, this contains all of your diagnostic imaging codes. It's further divided into subsections and categories. And the codes are included for physician supervision and interpretation of the diagnostic imaging data. The coding steps for radiology procedures are the same as Category 1 codes. Again, you look in the alphabetic index using the term radiology. You want to see the notes that directs you to code the more specific subcategories. And you see throughout the book, it gives you different examples in the figures of what those sections look like in the CPT book. Underneath the path and lab on page 346, you'll see to use a panel code, all the tests are listed under code selection that must have been performed. So if an individual test is supposed to be billed using a separate code for each one, you would not use a panel. But if everything on that panel was being done, you would use just the code for the panel. Coding for the immune globulins, you'll see figure 19-10. Same thing with the immunization and administration for vaccines and toxoids. These actually identify the vaccine product only. You would code in the immunization administration for the vaccine and toxoid subsection. Your home health procedures and services. These are used to report services that are provided in the patient's home. And figure 19-12 at the bottom of page 347 shows you an example of what your HCPC book would look like. So across the top, you would see the heading that you would start to look under. You would see the code range, the subheading, the HCPC code, and then the description. You do have two coding levels within the CPT and the HCPC book. The first code, the CPT codes were developed by the AMA, and they were published into the current CPT manual. The level 2 are your HCPC codes, and those were developed by CMS to describe the medical services and supplies that are not covered in the CPT manual. So ambulance services, TENS units, walkers, anything that is considered a durable medical equipment, or screening services for Medicare patients for blood pressure, colorectal screening, different stuff like that. And there is a separate HCPC manual for its own codes. And you would code in the HCPC book the same way you would code for your CPT and your ICD-9 book. Down coding is usually, when you do that, it affects the reimbursement by lowering the amount received. You actually might have civil and criminal penalty implications if this is done to skirt insurance policy restrictions or any pre-existing condition clauses. So don't decide to change a code just because the insurance says, oh, well, we're not going to pay that code. That's actually fraud. If you do that, that is considered fraud. So also common for insurance claims examiners is to change procedure code on a health insurance claim form to a procedure code with a lesser value. Again, that is fraud. When we upcode, that is what is considered to bill a higher level procedure or service that is not supported by medical documentation. Again, know your stuff. Know whether or not it is the appropriate code. We don't always, the intention is not to unbundle or upcode, but you want to just make sure you're picking the level of detail that you need in the procedure codes as well. All right, any questions with this chapter before we move on to answers in the workbook? Okay. Page 139 in your study guide. Vocabulary 1 and
Sorry. Hello?
what?
I'm sorry?
The answer to number 1 in vocabulary,
2.
category 1.
Category 1. Okay.
Okay, number 2 is what, Jackie?
Bundle.
Yes. Number 3, Diane?
Abstract.
Yes. And number 4, Liz?
Guidelines.
Guidelines. 5 is category 3. 6 is eponym. 7, unbundled codes. 8, modifiers. 9, sections. And 10, acronyms. All right, so this is where I said don't code. So pull up your Google. And this is where Dr. Smith visits Eula Fairbanks, a patient with dementia in the nursing home for less than 30 minutes and performs an expanded problem-focused exam with MDM of low complexity. This, and you have to pay attention because this is a nursing home exam, okay? So I would put nursing home CPT code. Nursing home CPT code. And let's see. Nursing home. Okay. This one will be a little trickier. I did nursing home expanded problem focus exam CPT code or code, let's see. And you come up with established patient E&M score sheet, inpatient consultations, codes and documentation for E&M, evaluation and management documentation requirements. So let me see. Oh, let's try this. Evaluation and management CPT codes for nursing home. And it comes up with Evaluation and Management Services Guide, Centers for Medicare and Medicaid Services. That's one. And you can scroll through that. Let's see, let me just look real quick. No, that's not going to. E&M CPT codes, let's see. Okay, I just found a CPT E&M quick reference app. It is www.cmaapp.org. www.ama-assn.org. Again, it's a CPT E&M Quick Reference App, www.ama-assn.org. When I click on that, it brings up, perfect, a place where I can put in a code. So let me see, does it work? Well, if you have a smartphone, it will help. Let's see.
Working for me.
Nope. Okay, so that was one. Anyone find anything else?
I'm looking right now, waiting for it to pop up.
I'm on Find a Code, but I can't find the exact thing we're looking for.
Yeah. Nursing home. Nursing home. E-code. No. Wait.
So fucking nasty, dude. Everybody overheated and it took me a second. So,
Can we mute the background mic?
Category 1, elements, past, view symptoms.
Okay,
This is
Diane.
1995.
I'm on Find a Code.
Yep.
I'm on a page titled Skilled Nursing Coding.
Okay.
And then when I scroll down, it says the CPT codes used to report the initial visit include 99304 through 99306. As you can see below, the code description includes the level of documentation required for each service and the typical time spent with the patient. And then 99304 says, includes a detailed history and physical exam, and medical decision making of low complexity. Typical time spent is 25 minutes. Would that be what we're looking for?
Yes, something very similar to that. Yes.
Okay.
So we're looking for main terms in our CPT coding the same way we would look for our ICD-9 codes. So I'm trying to see. I don't remember what I used last time. I apologize. Um,
I think I found one, Doreen. Go to www.cms.gov, and it comes up Medicare, /Medicare. And then for this one, it's telling you the different codes for it. The key points, CR426.
okay, so
Chapt.
nursing facility services 99304 through 99318 or 99, okay. Or skilled nursing facility CMS manual system 99356. So these, we're not finding these as easily as we would the ICD-9 codes, but you get the idea that, so for number one, we would start with nursing home for less than 30 minutes. They're doing an expanded problem focus, so we know that that's at least a level 2. And then we know that the medical decision making is low complexity. So whenever we bill an E&M, it's always going to be 2 out of the 3. You need 3 components. Remember we talked about that in the lecture? So the low complexity kind of ends up down on the totem pole because the doctor spent 30 minutes and did an expanded problem focus exam. So we know that for this one, we would actually choose a 99335. And if you Google CPT 99335, it tells you that that is a domiciliary or rest home code. All right, let's look at a few more just to look at main terms here. Number 2, Jessica Lundy, a newborn, was admitted to the pediatric critical care unit after her birth, where Dr. Williams provided her initial care. We want to look for a code that is pediatric critical care unit. Okay, that's what that one would be. Over on 3, because Lucille Westerman had multiple health problems, she was admitted for observation after a fainting spell. The doctor took a comprehensive history, performed a comprehensive exam, and then made medical decisions of high complexity regarding her care. For this one, we would look for admission for observation. So this would be observation care. And we know that we have 3 of the 3 components. So for this one, so we would look up observation E&M codes. Next one, number 4. Dr. Ray saw Tammy Luttrell in the office as a new patient. He took a detailed history, detailed exam, and the medical decision was of low complexity. So what do you think we would do for this one, Liz?
New patient?
Yes, office visit, new patient. And because it's an outpatient, I can tell you right now that's probably a 99203. All right. Number 5, Sylvia Julius saw Dr. Bridges for her allergies. Okay, so I'm going to assume that she's an established patient. He did a problem-focused exam, problem-focused history, and straightforward decision regarding her care. An established patient, that level is a 99212. Bonnie Sadler comes to the office to have blood work drawn for an obstetric panel. What's an obstetric panel, Diane?
I'm not sure.
Okay, that's fine. Obstetric panel is a pathogen lab. So we would look up obstetric panel CPT. Office charges for Bonley Sadler, a college student, for drawing a blood specimen. What is the code for venipuncture? So we would do venipuncture CPT code. Terry Smithson had laparoscopic gastric bypass surgery using the Roux-en-Y procedure, or Roux-en-Y procedure. Roux-en-Y procedure is named after someone. We would Google Roux-en-Y procedure. Kim Arendt had an outpatient kidney imaging study with vascular flow to make sure her kidneys were functioning normally. What do you think that would be, Liz?
Outpatient kidney imaging?
Yes, and when you think about that, that's probably an MRI. Okay, I'm guessing, but I would do imaging study of kidney with vascular flow, CPT. Georgie Ebersol, blood drawn for total bilirubin. Code the blood test. So I would code bilirubin panel, or total bilirubin panel. Roy Messing's urine was tested for total protein. That's a pathogen lab. So I would Google urine tested for total protein, CPT. Okay, so is everyone following how you would kind of pick these things out?
Yes.
So I don't want you to go through and do them all, but I want you to try some just to see what you come up with, and we can go over them in a few weeks just to kind of see what you picked to do and what you got, if you were kind of on the mark or not. So we didn't we didn't get a chance to go over any EHR tonight. What I would like you to do, just for the next class, which will be in 2 weeks. 3 weeks, right? Yeah. So that will be January
7th.
7th. So January 7th. Let me just look at the book real quick here. Make sure. 20, 21, 22. All right, let's do 20 and 21. Go ahead and read the chapters in your Kin's book. And go ahead and do the exams online if you wish. And in your electronic health records,
Doreen, you want us to do the exams on 20 and 21?
yes, do 18, 19, 20, and 21.
Okay.
Okay, and then if you want to go ahead in chapter 3 of your sim chart book, you have EHR exercises in your sim chart book, just in chapter 3 only. You did 1 and 2, right? Which was add a new patient and